initially when these drugs came, we were using it only in chronic patients who were really not admitted. And we know that the mortality in acute decompensated heart failure is also very high. So can we really start it early, pre-discharge, or at follow-up? Initially, it was all at follow-up. And what precautions should be taken? Well, to answer that, a new study appeared called Pioneer Heart Failure Study. This was done in patients who had acute decompensated heart failure with less than 40% ejection fraction. And they were stabilized on diuretics, as you know, and some of them had enalapril, etc. And after 6 hours of stabilization, this means there was no increase in diuretics, etc., no increase in IV vasodilators. They were started on ARNI. The target was to reach about 100 milligram twice a day, and they were compared with enalapril, 10 milligram twice daily. And this was a blinded study for 8 weeks. And this was to see the safety and tolerability and the clinical outcomes. And again, clinical outcomes were very significant. So among patients with heart failure with reduced ejection fraction hospitalized for acute decompensated heart failure, the in-hospital initiation of ARNI led to a greater decrease in the NT-proBNP. As you see on the left-hand side, the NT-proBNP significantly decreased because of use of ARNI. And the clinical outcomes like cardiovascular death and hospitalization also decreased significantly. So this is an 8-week study. So there was a benefit seen, and it was quite safe. So one could use it as early as possible, as soon as a patient of acute decompensated heart failure stabilizes in the hospital, to start in the hospital, and you will get additional benefit, as has been shown, as compared to ACE inhibitors in this trial.